Good afternoon. Thank you for joining today's webinar on screening and assessment for co-occurring substance use and mental disorders. My name is Allison Upton. I'm a Senior Policy Analyst at the Council of State Governments Justice Center, and I will be moderating today's webinar, which is hosted by the National Reentry Resource Center. To give you an overview of today's webinar, first we will do introductions of our panelists and provide an overview of the Bureau of Justice Assistance and the Council of State Governments Justice Center. And then we'll hear from Dr. Roger Peters from the University of South Florida, who will present on prevalence and screening and assessment options and considerations for co-occurring disorders. At the end of the webinar, we will have time for questions and answers. So I'd like to do some introductions of our speakers. First, I would like to introduce Mr. Andre Bethia, who is the Policy Advisor for Corrections at the U.S. Department of Justice's Bureau of Justice Assistance. Previously, Andre served as the Director for Program Operations and Policy at the New York City Department of Correction, where he managed external relationships with community-based organizations and research institutions, as well as developed policy and curriculum, identified best practices, and supervised programmatic initiatives for adolescents and young adults in custody. Andre's career in criminal justice began as an analyst for the New York City Police Department, but he also previously worked as a legal coordinator and provided law, library, and research services for people in custody at the New York City Department of Correction. He has a bachelor's degree in criminal justice from the John Jay College of Criminal Justice and a master's degree in library and information science from the Pratt Institute. Our second presenter is Dr. Roger Peters, who is a professor in the Department of Mental Health Law and Policy at the Louis de la Parte, Florida Mental Health Institute at the University of South Florida, where he has served as a faculty member since 1986 and as department chair from 2004 to 2011. He holds a joint appointment in the University of South Florida's College of Public Health. Dr. Peters received his PhD in clinical psychology from the Florida State University following completion of a pre-doctoral internship at the University of North Carolina School of Medicine and is a licensed psychologist in Florida. He currently serves on the Florida Supreme Court's Task Force for Mental Health and Substance Abuse Issues in the Courts and has been a faculty member of the National Judicial College since 2014. Dr. Peters also serves on the editorial boards for the Psychiatric Rehabilitation Journal, the Journal of Dual Diagnosis, and the Drug Court Review. He is the lead author of the monograph, Screening and Assessment of Co-occurring Disorders in the Justice System, which is published by SAMHSA in 2016. In 2015, Dr. Peters served as a Fulbright Scholar at the University of Cape Coast in Ghana and received a second Fulbright Specialist grant in 2017 in Paraguay. And again, I'm Allison Upton. I'm a Senior Policy Analyst at the CSG Justice Center, and I'm a member of the Behavioral Health team here, where I provide technical assistance to Second Chance Act, co-occurring disorder grantees, and I also do project work in this area. And so I want to thank all of our speakers today for your participation in the webinar. Thank you very much. And just for some housekeeping items to all the attendees, just want to really mention to you that anytime during the webinar, you can ask a question by typing it into the Q&A panel on the bottom right-hand portion of your screen. So this includes both technical and content-related questions. We will try to reply to technical questions in the chat window as we go. For the content-related questions, we will keep a running list and address them all at the end of the webinar. We will do our best to get through as many questions as possible. If you encounter any technical or audio problems during this webinar, please call WebEx Technical Support at this number, 1-866-229-3239. That is, for technical problems, call WebEx Support at 1-866-229-3239. Please understand that there are some technical issues that you may not be able to resolve. For this reason, we are recording the webinar and we will post it on our website at csgjusticecenter.org/NRRC. We should have the webinar posted online by the end of next week. And now I'm going to turn things over to Andre Bethia to talk a bit about the Bureau of Justice Assistance. Andre?
Thanks, Allison. Good afternoon. My name is Andre Bethea, and I am the Policy Advisor for the Second Chance Act Reentry Program for adults with co-occurring substance use and mental disorders in the Policy Office at the Bureau of Justice Assistance, also known as BJA. At BJA, our mission is to provide leadership and services in grants, administration, and criminal justice policy development to state, local, and tribal jurisdictions. Specifically, BJA provides funding to support law enforcement, combat violence and drug-related crime, and combat victimization. Through the development and implementation of policy, services, and sound grants management, BJA strengthens the nation's criminal justice system and restores security in communities. The Second Chance Act has supported over $300 million in reentry services since it was passed in 2008. There have been 96 total awards through the Second Chance Act Co-Occurring Grant Program for a total of $42 million since 2010. We are excited for this cohort of co-occurring disorder grantees to use best practices in screening and assessment as part of their programs to help them advance successful reentry and recovery for participants. I will now turn things back to Allison to continue with the training introduction.
Thanks so much, Andre. So I'm going to give some background on the Council of State Governments Justice Center and the National Reentry Resource Center, or NRRC for short. So the Justice Center is a national nonprofit, nonpartisan organization that serves policymakers at the local, state, and federal levels from all branches of government. Staff provides practical, nonpartisan advice and evidence-based, consensus-driven strategies to increase public safety and strengthen communities. On this next slide, you can see some examples of publications released out of our office on a variety of topics, including justice reinvestment, reentry and employment, and adults with behavioral health needs under correctional supervision. The Justice Center operates the NRRC in partnership with the Bureau of Justice Assistance, and since 2009, the NRRC has provided technical assistance to more than 600 grantees. The NRRC also serves as a source for user-friendly, interactive information on best practices in reentry. We're always adding new content to our website, and we send out a monthly newsletter that provides information about the latest research, funding opportunities, webinars, and other news about reentry. So we really encourage you, if you haven't done so already, to sign up for the NRRC newsletter and our other newsletters. To do so, please visit the link that will be on your screen at the end of today's webinar. Okay, now we are going to shift into the main portion of our presentation today. So I will turn it over to Dr. Roger Peters to discuss screening and assessment of co-occurring disorders. Dr. Peters?
Great, thanks very much. It's good to be here today, and thanks everybody for joining the webinar. I would like to thank the Council of State Governments and the Bureau of Justice Assistance for hosting and organizing the webinar. And hope this will be helpful to all of you as grantees. I've had a chance to look at your programs, information supplied to me by Council of State Governments, and it's really exciting the work that you're doing on all different fronts across the criminal justice system. So here's just a little bit of an overview of what we're going to be covering today. And as was mentioned, we'll focus a little bit on prevalence of co-occurring disorders in the justice system real quickly, going over some of the numbers of what are we talking about in terms of how frequent mental disorders and substance use disorders occur and co-occur. We'll look at some instruments that are evidence-based for screening and assessment of co-occurring disorders in different settings. We'll also look at different points across the system and how screening and assessment differs a little bit across those points in the justice system at which your different grantees are working. And then finally, we'll close with some considerations and thinking about approaches that you can tailor screening and assessment for a population of offenders with co-occurring disorders. And we'll leave some time for questions and answers. So let's move, we've covered each of these already. This is our outline for today in terms of the topics. So we'll get right into it. In terms of people with co-occurring disorders, as you know, These are individuals that cycle pretty rapidly through the justice system and the treatment systems. They're well known to police, to judges, to emergency room staff, crisis stabilization units, and so forth. This population experiences considerable problems when they're not taking their medications for mental disorders, when they're not engaged in treatment, also when they're experiencing mental health symptoms or using illicit substances, alcohol or drugs, actually. And we know with this population, interestingly, that it doesn't take a lot of either drugs or alcohol to trigger recurrence of mental health symptoms and also destabilize and create additional stress in their living situation, their social supports, leading them oftentimes to go off medications and so forth, and to experience the recurrence of the mental health symptoms and disorders. So this is also a group, as you know, that have poor outcomes in traditional treatment programs, either substance abuse treatment programs or mental health treatment programs for a number of reasons. And the primary one, of course, is that both disorders aren't given equal treatment in these settings, nor is there given enough attention to the interactive effects of the disorders. So we have challenges, and your programs, I think, are models for the country in terms of operationalizing how we work with this population and how we identify, screen, and assess for co-occurring disorders in this setting. So I'd like to start with just an example of one individual with co-occurring disorders from my home area, Tampa, Florida, Hillsborough County. And this individual has been a frequent participant in the 13th Circuit Court System in Hillsborough County, Florida. And you'll see here a 10-year span looking at this person as he changes over time without long-term engagement in treatment, but rapid involvement in the criminal justice system. So going from a fairly normal-looking 22-year-old on the left-hand side to someone who perhaps could be a participant in the motorcycle gang that looks down and out and disheveled and worse for wear, certainly has aged beyond his years at age 32. I don't think this is atypical of the population we work with. This would be a snapshot then of this individual's rap sheet, basically, the history of offenses over this period of time. We have 28 arrests here. Most, as you can see, if you can read this, I think you can, I think most of these arrests are for nonviolent offenses, which is also pretty typical for this population. Lots of arrests, 28 arrests, most for nonviolent offenses, leading to almost 900 jail days at a huge cost to Hillsborough County and Tampa. So when we can intervene with this population, even with a small number of individuals like this, we have a huge impact financially and also in the lives of these individuals and stabilizing them and making the community safer to live in. So I'm going to cover some of these slides fairly quickly, if you'll indulge me. And I think most of this information is fairly well known to your staff who works very closely with this population. So we know that we have adverse outcomes for people with co-occurring disorders in the justice system. They cycle through the system, as we mentioned, pretty rapidly, particularly when they're not stabilized or engaged in mental health and substance abuse treatment, also when they're using drugs or alcohol. They tend to stay longer in jail. They don't bond out. They don't have money for bond. They're assumed to be dangerous in many cases, a threat, and they're certainly in acute crises and acute symptoms related to mental health and intoxication. They serve longer sentences in jail and prison in comparison to other individuals without the dual disorders. They have higher rates of technical violations on probation and parole, and oftentimes this would be in the absence of threats to public safety. So it's interesting that, the public perception of this population is one that's violent, and in fact, we know that that's a myth, and that these individuals are 3 times as likely to be victimized in custody or other settings than they are to commit acts of violence on people in the community or in institutional settings. They oftentimes are the focus of use of force by correctional staff, and as a result of their behavioral issues. Their symptoms are oftentimes placed in administrative segregation or solitary confinement. And as you know, that their disorders typically worsen under these conditions. It creates more stress, and we oftentimes see a resumption of the psychotic symptoms, other symptoms of depression, bipolar. And this has actually led to a lot of class action cases around the country. And by the way, we're seeing class action cases now also with failure to provide a medically managed detoxification for people with substance use disorders. And finally, we see higher recidivism rates following release from custody for this population, both from jails and prisons, and particularly if they're not engaged immediately in treatment services. So that's where your programs are really doing a good job, I think, in providing a warm handoff and a continuum of care following release from jails and prisons into the community. So what about prevalence rates? Let's touch on these. Again, I want to go fairly quickly through this. I think most of this is self-evident to our grantee group. First off, as you know, we have terrifically high rates of substance use disorders among offenders, all different settings, whether it's probation, parole, court-based individuals, offenders in the courts, prisons, jails. 60% have a diagnosable DSM substance use disorder. And using the old DSM-4 criteria of substance dependence or abuse, about 40 to 45% of offenders actually have a substance dependence disorder according to DSM-4, and about 20% have substance abuse disorders. So really weighted towards the more severe end of the spectrum. And this would be individuals with at least moderate to severe disorders using DSM-5. So 60% with moderate to severe disorders that really are in need of treatment. Vast majority of these individuals are in need of treatment. So what about mental illness? Well, again, we have very high rates, and I'm going to scoot back to that last page just for a second, sorry. You look at the general population rates of about 9%, so about 6 to 7% times the higher rates of substance use in comparison to the general population. And here again, you'll see the comparisons, and it's about the same. It's about 6 times the rates of mental disorders that we find among offender populations in comparison to the general population. And these are major mental disorders. These are primarily depression, bipolar, psychotic spectrum disorders. You'll see in jail and prison high numbers and some differences according to male and female offenders. Female offenders having higher rates of depression and PTSD in comparison to males, but very high rates. We also notice that there's a greater number of prior incarcerations among this population than other offenders, and less than a third of these offenders are actually taking medication at the time of arrest. So we'll look at that in the next few minutes at in terms of treatment for this population and what are the rates of active treatment. So here's the prevalence rates of mental disorders among prisoners, jail and prison populations. Again, you can see the rates across the different disorders, very high rates, depression, bipolar, schizophrenia, and also post-traumatic stress disorder. This, by the way, I think is really underestimates PTSD or post-traumatic stress disorder. We find that, we'll talk later about this, but we find in our populations 50 to 75% of offenders really tend to have symptoms of PTSD. And we'll look at some strategies for screening and assessment of that particular disorder. So when you have a mental disorder, it's almost a given that you have a co-occurring substance use disorder, and that would be on the left-hand side of this graph. So these are individuals in correctional settings who have a diagnosed mental disorder, and you can see that about 75% of them have a co-occurring substance use disorder. And really, there are very high rates also of people without mental disorders having a substance use disorder. But for those that have an identifiable mental disorder, the rates are much higher. Finally, I told you I'd share with you some information about treatment history among the offender population. And this is in general among all offenders who are entering jails across the country, as it turns out, in a large-scale study, ASAM-2 study, looking at 18,000 plus arrestees to metropolitan jails primarily. And you can see the vast majority of offenders, even though we have high rates of mental and substance use disorders, the vast majority of these individuals have never been in treatment, despite the high prevalence rates. And you can see as you go further to the right, there's a huge treatment gap for those who need substance use treatment and those who actually have had treatment in the past. So 60% have diagnosable substance use disorders, only 27% have ever been involved in services for those disorders. And if you look underneath the surface, what they're actually talking about in terms of treatment could be 12-step groups or very non-intensive programs that might be found in community correctional settings or institutional settings. Same holds true for mental health treatment. We saw the high rates going up to 31% in offender settings, and yet only 4% had received mental health treatment for those disorders. So lots of individuals in your populations that have these disorders, particularly co-occurring disorders, yet people really have not been consuming services and not really familiar with what treatment is. And so I think all of us, it's a mandate for us and a challenge for us to engage people in services and also to inform people about what the benefits are, what we can provide, and how that can help them in their lives in terms of other types of personal goals that they have. So let's move to some instruments for looking at co-occurring disorders. And we'll look at some evidence-based instruments for each of the major disorders that we're talking about. First off, just a quick slide here. I won't spend a lot of time on this, but again, we have very high rates of these disorders, and so it's really important to provide universal screening and assessment as needed for these disorders. We know that working in the justice system is a really good opportunity to gather information about these disorders for individuals who have not been involved in treatment, have not been identified to engage in services in the past, yet have high rates of need for these services, and oftentimes the disorders are connected directly with the likelihood for reoffending. So we can interrupt the cycle of recidivism in many cases by treating these disorders. We know that undetected disorders lead to relapse and to dropping out of treatment and to recidivism, as mentioned. We know that a good screening and assessment system allows for quick engagement in services, including specialized services for things like post-traumatic stress disorder, and identifying with the treatment team, with the judge, with the court team, if it's a drug court or a mental health court, or with a specialized team in jail that's working to triage for classification and housing, as well as treatment services. And then, of course, in prison classification and placement in specialized services. So this all helps us to provide a vocabulary and a way to link up with other staff and sharing information about what's needed to triage individuals into services. We also know from research that providing a comprehensive assessment leads to better outcomes across drug courts and other criminal justice settings. So it really just makes sense to be able to fast-track people into services, involve them in specialized co-occurring services, preventing premature dropout, providing effective treatment matching, we'll talk more about that, and placing people into different levels of care and to housing units accordingly. All right, well, so I recommend for all of our criminal justice settings that we provide universal screening for all offenders for the following types of issues. And I think you'll agree with me because of the high rates of these disorders and also the importance of criminal risk. By that I mean risk for recidivism. So we'll talk more about each of these as we go forward and look at some individual instruments for screening and assessing for these areas. But again, I think we need to build into our systems each of these areas. We need to provide screening and follow-up assessment is needed for these content areas My experience in providing site visits around the country for the Justice Department and other organizations is that many programs do a good job with one of these areas or two possibly, but they don't provide comprehensive screening or assessment in all of the areas. And typically there's some major gaps if they even provide screening or assessment in one or more of these areas. So it was mentioned earlier, Allison mentioned that monograph that we developed for SAMHSA 2016 publication that's available online free of charge is Screening and Assessment of Co-Occurring Disorders in the Justice System. And here you can find much more information than we'll go into today about individual instruments for screening and assessing each of these disorders, the comparison between instruments in terms of how effective are they, how reliable and valid, how much do they cost, where do you access these, how much training is required, how much time is involved in terms of screening and assessing using the particular instruments. And there's also quite a few tips about different approaches for customizing screening and assessment for the population of offenders with co-occurring disorders in your settings. So take a look at that if you have a chance and you're interested. So let me turn to some specific instruments. And these are several instruments that I would recommend that are evidence-based, and these instruments are primarily public domain, free of charge. And there are many other instruments as well for each of the types of disorders that we'll be talking about. So I won't go into a lot of detail about these instruments. You have the Texas Christian University Drug Screen 5, which is a mirror of DSM-5 criteria for substance use disorders. It aligns very carefully with DSM-5, and it really is the instrument I'm recommending in most cases for programs to use as a first-line screening for substance use disorders. There are other instruments available, many other instruments. Simple Screening Instrument is also free of charge, developed by SAMHSA years ago, that also screens for a range of disorders. The Assist is available from the World Health Organization. That's also an evidence-based instrument. There's others like the GAIN instrument that many of you may be using, other individual instruments as well for either alcohol or drug disorders. So one reason I recommend the TCU Drug Screen 5 is that it looks at both alcohol and drugs, and of course is aligned with DSM-5. We'll look in just a minute. There's also a new opioid supplement to the TCU Drug Screen 5, which I think you'll find very interesting if you haven't seen this, and I'll talk more about that in a minute. Before we move to that, I want to just share with you that not all screening instruments are equally effective. And as part of the research that we've done and that's shared in the monograph that I mentioned a few minutes ago, we looked at the comparative effectiveness of different screening instruments in contrast to the SCID, which is really the gold standard structured clinical interview for DSM. And we found that there's really quite a bit of variation in the validity of the instruments. We found, for example, the SASE instrument was among the least effective for offender populations, and yet it's been used quite often. And at one time, it may have been the most commonly used screening instrument for substance abuse in the country, and perhaps in justice settings as well. But the SASE is actually among the worst screening instrument that you could use, and tends to over-identify people who have substance use disorders and to place them in programs with intensive services where they aren't really needed as much, or the intensity level the high intensity level isn't required. So be careful about the instrument you use. Other instruments that are commonly used that are problematic include the MAST, the Michigan Alcoholism Screening Test, and the CAGE. CAGE is a really quick instrument. Both of these instruments have problems with validity, and I discourage you from using those. And You know, the easy alternative would be one of these instruments here on the slide. The GAIN is also GAIN Global Appraisal of Individual Needs is a proprietary instrument, costs money, but also is effective and has good psychometric properties. So let's move on to the TCU drug screen. I just want to mention that there is an opioid supplement now to the TCU drug screen 5. Now, this instrument is available through the Texas Christian University Institute for Behavioral Research, or TCU IBR, and you'll see the link to the instrument here on the screen. If you just Google IBR TCU, you'll find a whole range of materials at that website, which are incredible. They have treatment protocols, manuals for all different types of populations, but also a whole series of screening and assessment instruments, including the TCU Drug Screen 5, which I think right now is probably the most commonly used substance use screening instrument in the justice system in the U.S. and is getting broad usage internationally as well. So I did want to mention the opioid supplement that was created in 2017 to address the epidemic, obviously, in the United States, and the need to gather more detailed information about opioid use. And so this supplement to the instrument is several pages long. I have it in front of me, and it really looks at the types of opioids that people have been using, whether it's heroin or oxycodone, fentanyl, other types of opioids, how many times they've injected, if they have injected in the past, whether or not they've overdosed, other types of patterns of use, whether they've used it for medical purposes or non-medical purposes, and also whether they have been receiving medication-assisted treatment, or MAT. And so that's really important to us, if they've been on methadone, buprenorphine, naltrexone, and what the history has been of use of that. So I'd encourage you to take a look at this supplement. I think this would be a valuable asset for many of your programs if you haven't seen this. So for mental health, what about the instruments here? Well, the good news is, again, we have many evidence-based screening instruments for mental health, and these typically cover the major disorders: major depression, bipolar disorder, schizophrenia, other types of issues like suicidal ideation and risk. These are all commonly used. I won't go into detail on these instruments, but again, these are all free of charge. They're all available on the internet. So by a brief scan, you can identify these and download these and print these off. These are very quick to administer, including all of the substance use instruments and the mental health screening instruments take about 5 to 8 minutes to administer. So they can be done either verbally or by paper and pencil test very easily. They don't require training from a trained clinician, for example. So encourage you to take a look at these. And again, these are described in more detail in the monograph that is part of your slide set for this presentation. So here are the major disorders that are covered in each of these types of instruments. The trauma disorders, we have a special set of instruments we'll go into in just a few minutes that I'll share with you. So we want to look at that disorder particularly in more detail. And actually, the screens don't do a great job of identifying trauma symptoms. And so there's a need, that's a really good reason why we need to provide a separate trauma screen and assessment to follow as needed, given the high prevalence rates and the fact that the typical mental health screens don't go into depth on trauma symptoms. So here you have the rationale that about 75% of females, and surprisingly for some people, over about half of male offenders also have a history of PTSD and trauma. The males are a bit less likely to self-disclose this, and so having a structured screening instrument is really helpful to identify these disorders. The initial screen, as with the other types of instruments for the other disorders, don't have to be conducted by a licensed clinician. These are non-proprietary for the most part, and we certainly need to follow up with a more detailed comprehensive assessment for post-traumatic stress disorder and history of trauma following a positive hit on one of the screening instruments. So I think we find that these disorders are oftentimes overlooked, right, in our screening process and in our treatment programs. And we can have people who live in these programs and live in our justice settings for months, years at a time, in which these disorders aren't identified properly. And we misattribute the symptoms oftentimes to low motivation, hostility, depression, other types of things, borderline personality disorder, anxiety. And so we misdiagnose and we don't provide proper treatment for these disorders. And oftentimes this leads to dropout and certainly doesn't lead to the good outcomes that we need with our offender populations. So a really important reason to provide specialized screening and assessment for trauma and post-traumatic stress disorder. What about instruments? Well, again, the good news is we have a range of evidence-based instruments. These are described in the monograph, and I'll just touch on a few. The ones listed in red are examples of different types of screening. If you go right to the bottom of this diagram, you'll look at the most basic screening for the diagnostic symptoms that align with DSM-5 for post-traumatic stress disorder. And this instrument is commonly used, maybe the most widely used screening instrument for PTSD in the world right now. And it has good psychometric properties, reliability, validity. There's also screens for a history of traumatic events. And you'll see an example of this at the top. The top two items in red would be examples of screens that go into what kind of traumatic events have occurred in your life that have led to the symptoms that would be identified in that lower bottom instrument, the PTSD checklist for DSM-5. So it's nice to pair two sets of screens, one that looks at the symptoms and one that looks at the actual life events that led to the symptoms, because you'll need to know which are the critical life events in order to provide proper treatment for that set of traumatic events in the past to deal with that disorder. There's also diagnostic instruments. You'll see that on the top left and the lower left corner. So you've just a quick snapshot of some of the instruments that are available for use in justice settings for the different types of disorders. So we'll transition now to some other issues that are also important to screen for. And these would be, if you're familiar with the risk-need responsivity model, the R&R model, which is really commonly applied now in justice settings and other settings to work with offenders and identify areas that are most important targets for intervention and for risk reduction related to rearrest. This would be a set of the responsivity areas, areas in which we want to increase offenders' engagement in evidence-based treatment services in order to reduce recidivism. And so if you look at these key target areas, these are all areas that don't in themselves predict recidivism, but they are critical items, critical areas that would undermine involvement in evidence-based treatment if they're not addressed, right? So if you're living under a bridge, you're homeless, you're not going to be a good participant in substance abuse treatment or mental health treatment, any other type of treatment. That has to be dealt with first and foremost. Transportation, similarly. Health problems, financial support, the whole range of things here are what we call responsivity issues that will help you to engage offenders in evidence-based treatment. They in themselves don't reduce the risk for rearrest, but are critically important in the screening process and the assessment process as you work with your offenders who have co-occurring disorders. All of these, as you know, then, can undermine effective treatment and supervision services if they're not addressed in screening and assessment. So the other area, and we could spend hours and days probably on assessment and screening for criminal risk, and we don't have that amount of time today. And I think you've probably been exposed to other types of training in this area. So I'm just going to cover this very briefly. and we'll share with you a few instruments that are examples of ones that might be used in your settings as well. So importantly, we want to select the vendors for our programs that are high intensity and high resource services like the ones that you have in your grantee programs for those individuals who have high risk for reoffending and also have high need for substance abuse treatment and mental health treatment. We want to engage this group in intensive services. We don't want to mix them with low-risk individuals. That's problematic. It leads to dropout and poor treatment outcomes for both the high-risk and low-risk populations if we do that. In order to provide risk screening and risk assessment, we need to look at both static factors, things that are not changing over time, and that's primarily criminal history, age at first offense, the number of prior felonies, number of prior convictions, history of violence, those type of things, history on criminal justice supervision. All of those things are historical factors that are very closely related to the risk for rearrest, highly predictive. In fact, the most predictive of all of these factors. But coupled with the static factors are things that can be changed, or what we call dynamic risk factors. And these are actually the targets of our interventions in our treatment programs. And of course, the good news is that we can change these areas of individual psychosocial functioning to decrease risk for rearrest over time. And these are things like, we'll go into that in the next slide. These are things like substance abuse, criminal thinking, the criminal peer network, employment, and so forth. So what you see in front of you, the static and dynamic risk factors, are those things that are essential components to criminal risk screening and criminal risk assessment. And here are the dynamic risk factors. Again, if you'll take the top 3 of those, coupled with the criminal history that we just talked about, you'll find the most 4 predictive factors related to rearrest. However, the following factors are also important, independently contribute to the predictive model for looking at the chances for rearrest among your offender populations. One interesting note at the very bottom, we need more research on this, but at least one study in the United States with over 1,000 consecutive admissions to the San Francisco jail system with a mental health population has identified PTSD, or post-traumatic stress disorder, as an independent predictor of rearrest. And so it may be that this is also a dynamic risk factor that needs to be considered as we gauge and assess the risk for criminal recidivism. All right, so very quickly we'll look at some of the instruments, and you're probably familiar with a number of these. One thing I would tell you is that most of these instruments are very similar in terms of their composition. And so it's well known what the predictive factors are that we just covered very briefly in terms of the static and dynamic risk factors. And so the risk assessment instruments, the risk screening instruments, each cover similar components. And there's not a huge amount of variability typically in the outcomes, the classification accuracy of these instruments in predicting the likelihood for rearrest as people enter your programs and are released from your programs, discharged, and eventually are in the community. So these are just some examples of instruments. The top 2 instruments here are actually risk screening instruments. The RANT instrument, which was developed originally for drug courts, the LSIR screening version was used originally in community correction settings and has been used now widely in many different settings. The analog of the LSIR screening version is listed down below, the Level of Service Case Management Inventory, LSCMI, which is the most commonly used risk assessment in the world and has very good psychometric properties. Another example of a risk assessment instrument that's now very commonly used and being tailored and customized for different states across the country in the U.S. is the Ohio Risk Assessment System, ORAS. And both of these are very viable and important vehicles for assessing risk and have good properties psychometrically and classification accuracy. So without further ado, we'll move beyond that and I did want to include the risk assessment because it's a key area of screening and assessment for our populations with co-occurring disorders. And really is important to include that in our case workups, our treatment plans, our case plans and treatment plans for these individuals that consider dynamic risk factors for recidivism, and also look at changes over time in risk level, which can then actually change the type of intensity of treatment services and the intensity of supervision that's provided to our individuals. Let me talk for a minute about the location of screening and assessment for co-occurring disorders in the justice system. I won't spend a huge amount of time on this area, but I know that your grantee programs really cover the spectrum from court-based programs to jail-based to prison-based, reentry programs, and also law enforcement as well. So we cover the gamut. And I think one of the key things to consider is that we want to provide early detection, and also we want to provide screening and assessment, well, particularly screening at each of these points across the criminal justice system. We want to divert non-dangerous persons from the system and quickly engage these individuals with co-occurring disorders in services to stabilize their disorders and to treat them, prevent rapid cycling through the system, preventing relapse and recidivism. So I think, as you all know, that oftentimes we may not detect one or more of the disorders at a given point in the justice system. And so the overall picture is one in which we want to provide multiple opportunities to identify mental health and substance abuse problems among this population. And we'll go into each of these areas in a bit of detail. But for law enforcement, for example, we want to look at providing screening within the context of crisis intervention teams, triage centers for screening and referral to treatment, drop-off centers, for law enforcement that are now more widely used than they have been in the past, and each of the different settings we'll talk about in just for a few minutes. So for law enforcement, screening's kind of a fluid process. It's not one that happens in an office-based setting like it might in some other criminal justice settings. We don't typically use structured instruments in the field settings. We're relying on observation of acute symptoms and then referral to acute care settings like CSUs and triage centers, as mentioned. We have specialized training for the individuals in law enforcement settings and teams that operate in these settings, and many of the grantees are actually operationalizing those concepts for Second Chance Act. So we have mental health first aid training, crisis intervention teams or specialized teams that work with de-escalation of aggressive behaviors related to mental health and substance use disorders, and also trained in how to divert individuals to treatment services. Community triage centers are now available in many areas of the country, provide a drop-off center for law enforcement where we can conduct on-site screening and assessment for co-occurring disorders, provide involuntary placement as needed, and refer to other community services. So also then the second intercept, we call it intercept or point in the justice system, would be initial detention and initial court hearings. And here again, we want to quickly determine eligibility for people to be released from custody settings, from jail, and to identify their acute needs. We want to link people with community behavioral health services as quickly as we can, provide a brief standardized screening for co-occurring disorders and criminal risk if we can, and across different settings, at jail booking, pretrial, court clinics, diversion programs. So really important. Here's an example of probably a more structured ability to provide screening and assessment in these settings. But yet, a lot of people are really there in these settings for a short amount of time, and so sometimes it's hard to predict how long we have them. And perhaps the best we can do for some of these individuals is provide a good screening, identify the acute needs, and provide that information in linkage with other community services as people are released from custody. So for jails and courts following booking, we want to certainly identify needs for in-jail services that might be available and further assessment. And here we have a bit more time, presumably, for some of the individuals to provide a case plan, treatment plan that will inform disposition and sentencing decisions. Really important. Working with the defense bar, advocacy staff, case managers. Ideally, this would lead to a pre-sentence report that would be available to the court that would identify specific needs related to co-occurring disorders and specific placement in services that are needed, with recommendations about the intensity of supervision and treatment. And again, these kind of assessments that we would do at this point would focus on both co-occurring disorders, the range of other psychosocial needs, the barriers to engagement in services, the responsivity issues, housing, financial supports, and so forth that we talked about, and also criminal risk level. Prison and reentry settings. Certainly here we're going to identify the needs for services in prison. We have people for a year or more in prison, and we can provide intensive services in these settings. Also, we want to identify the need for further assessment and placement in the prison setting that's most conducive to providing treatment for those services that are needed. Reentry planning is a huge area for the grantees, and I think, again, assessment plays a big part in identifying a reentry plan. Here again, I think it's important to reassess for criminal risk that may have changed over the course of incarceration, more likely to change in a community setting, certainly in probation or parole, in terms of the individual risk level over time. But yet, criminal risk can be reduced even in prison settings or in jail settings over a period of 6 months or more. For example, with involvement in substance abuse treatment, educational programs that we know both of these types of dynamic risk factors are very highly predictive of recidivism, and the risk can be reduced significantly even with correctional treatment services. So we would want to do a reassessment of criminal risk at the point of reentry that would inform the type of settings that individuals are referred to and the type of supervision and treatment services that are provided. Certainly we want to share this information, and isn't this one of the hardest things to do, is to actually transfer this information to community-based settings from prison settings. This is, having a warm handoff that includes sharing of information with appropriate release, obviously, from the offenders for that. Really provides a much more effective transition, reentry to the community. Finally, community corrections. So this is where the bulk of offenders really exist and live. Here we're looking at the type of intensity of services needed and the level of supervision required. Again, we don't want to mix people with high risk and low risk kind of backgrounds in treatment groups or other types of supervision groups that may occur. We have lots of standardized screens for behavioral health disorders that can be applied in these settings, and also standardized risk and needs assessments to help develop a case plan. As I mentioned, I think there's even more of an opportunity for risk level to change over time in community corrections settings. Probation, parole, for example, in which individuals' needs related to basic needs of housing, vocational, educational, family supports may have been taken care of and improved over time. Also engagement in educational services, employment, and substance abuse treatment, all of which reduce the risk level, can be factored into whether or not people can leave supervision early if they're doing well, if they can be placed in less intensive services such as outpatient once or twice a week instead of intensive outpatient or residential for substance abuse treatment. These things can be titrated, can be changed according to the risk and needs that are assessed in the risk assessment instrument that you might provide. So really important to tailor the type of screening and assessment according to the different point in the justice system, the intercepts that we've talked about in the last few minutes. So what about assessment instruments and some considerations as we close out the presentation today? I want to share with you there are some examples of evidence-based assessment instruments for substance abuse, and I won't go into detail. The ASI is the most widely used assessment instrument for substance use disorders in the world. It was developed here in the country and is commonly used, takes about 45 minutes to administer. Also, the global appraisal of individual needs. I mentioned that before in the context of screening. There's also a family of GAIN instruments that you may be familiar with that include the several different versions of assessment. And then finally, I'd recommend the Texas Christian University website, which not only has the TCU Drug Screen 5 and the opioid supplement that goes with that, but also quite a few different assessment instruments that you can consider that are downloadable and free of charge that provide a comprehensive assessment for substance abuse needs, including other psychosocial areas that affect engagement and completion of substance abuse treatment services. Some of you are probably familiar with the ASAM criteria, American Society of Addiction Medicine. There is a set of assessment criteria, an assessment system that goes along with the ASAM criteria. These criteria look at the following 6 areas to look at the level and intensity of services that are needed for individuals in the area of substance use disorders and also co-occurring disorders. And so as you look at these 6 areas, they can vary dramatically across our offender populations, and the implications are that people need different types of services and levels of intensity and modalities of services. And so this ASAM system, which includes the ASAM criteria decision engine, a computerized assessment system that guides individuals in going through a series of components that will allow you to determine the proper placement to match people according to these 6 areas of need and the following areas of actual treatment services and modalities of treatment. And you can see these areas are available in many of the criminal justice settings, primarily community-based settings. They may be available to a certain extent in prison-based settings and jail-based settings as well. But for many of the programs in the justice system, they find it very useful to use the ASAM criteria, providing a structured, reliable way of treatment matching individuals to various different levels of services for substance use and co-occurring disorders. There are also a range of other instruments for mental disorders and substance abuse and co-occurring disorders, and here are just a few of those. I'll mention the Personality Assessment Inventory, which is an objective psychological assessment that is used to determine diagnoses, but also the level of impairment for people with mental disorders, the type of symptoms that people have. You also have the International Neuropsychiatric Interview, MINI, down below at the very bottom of the slide, which provides a 120-item structured diagnostic interview, which gives a diagnostic impression of the different major disorders along the mental health spectrum. And of course, if you want to get into a structured diagnosis, the gold standard, as I mentioned before, is the SCID, and that'd be on the right-hand side of this diagram. And this takes a little bit longer, 45 to 90 minutes, depending on the level of symptomatology, pathology of individuals who you're working with in the assessment process. There is an instrument that is used for assessing co-occurring disorders. It's not used very frequently in criminal justice settings, but that's listed on the left-hand side of the diagram, and this does provide a structured instrument to look at particular areas about lifetime and current diagnoses, the onset of the disorders, duration of symptoms, and designed specifically for co-occurring disorders. So very briefly, we'll just look at some of the types of assessment information that you would need to address in the assessment process. I won't spend a lot of time on this, but some things that are unique for co-occurring disorders would be the second bullet, for example. How do these disorders interact over the individual's history? And so one thing you'd want to ask, for example, is, has a mental disorder or disorders occurred only in the presence of using alcohol or drugs? In other words, could these be substance-induced disorders in which the drug or alcohol actually mimics the symptoms of the mental disorders, and people may have been placed on medications as a result of that for depression or something else, psychosis. So we want to ask carefully about the interaction of the disorders, other types of issues that affect treatment for co-occurring disorders listed here. We look at certainly other areas psychosocially, education, employment, also personal strengths and skills. This is an area that's overlooked oftentimes in the assessment process, and is one that we can, an area that we can really use to help build the treatment plan in areas that are really non-traditional, that also can reduce the likelihood for recidivism and can build on strengths that individuals have currently. One thing in the assessment process that we don't have good structured instruments for is the area of functional impairment. And some of the areas that affect treatment involvement would be cognitive capacity, things like attention, verbal encoding, the ability to understand verbal information, how people, basic reading skills, communication skills. How do people handle stress? People with a paranoid psychotic disorder may be not able to handle stressful situations. It may be that they're not good candidates for group treatment because of that, or other types of disorders that they may have. What's their social functioning like? Can they take part in groups and interact in a meaningful way? Or are they hostile and aggressive or isolative in these settings? So these are areas in which we don't have really typically good assessment instruments, but we rely on observation over time to identify some of these areas that I think are oftentimes more important than diagnosis in terms of matching people to the right types of services or determining eligibility for your programs, right? And again, the level of care that's required, what intensity of services are needed for individuals. So this would be an area for assessment that you would want to look at the same kind of criteria that's embodied in the ASAM instrument that we looked at before, the ASAM criteria. So just some quick areas here to consider. We want to have a blended screening that includes each of the areas that we talked about earlier. For screening, we're looking at acute symptoms, evidence that functional impairment, as we talked about, that's maybe more important than diagnosis in the screening process. We also want to mention that screening doesn't replace a more detailed assessment for treatment matching. So for example, if you administer the TCU drug screen, that doesn't tell you whether somebody is in need of outpatient versus residential care for their substance use disorder or co-occurring disorder. It gives you an impression of what level of severity of the disorder they have, but doesn't tell you about the type of placement that's needed. Does that make sense? In terms of assessment, on the right-hand side, looks like we don't have the headers here, but left-hand side is really considerations for screening. Right-hand side of this diagram is considerations for assessment, and we talked about each of these areas, I think, over time. In terms of the webinar today, we certainly want to reassess for motivation over time. Oftentimes, this is quite low to begin with, right, for individuals with co-occurring disorders who have not had success experiences or success in treatment. And we also want to reassess, as we talked about earlier, for psychosocial needs that may have changed over time, and also for criminal risk, because this can lead to a very different type of case plan or treatment plan for individuals who have reduced risk over time that then can be placed in less intensive and less expensive types of services in our programs. What are some of the challenges in selecting instruments? Well, one of the biggest ones is there's so many out there to choose from. I mean, where do you start? And so that was really the purpose of part of our webinar today, is to identify some of those where you might begin your process of looking. Or if you're using existing instruments, I know most of your programs are using standardized instruments, then what might you look at for optional instruments in place of the ones that you're using if they're not evidence-based, or if they're homegrown instruments, for example. So there's really a benefit in using standardized instruments in your settings that have proven psychometric properties and cutoff levels, if it's a screening instrument, for example, that would tell you whether or not somebody needs a more in-depth assessment for that particular disorder, whether it's a mental disorder or a substance use disorder. I'll just go to the last point again. There are instruments out there that have poor psychometric properties, such as the SASI, that you want to avoid. And many of these are commercially marketed, right? So they're maybe the most popular instruments in terms of familiarization that people have. They know the SASI. They may not know the TCUDS instrument because there's nobody marketing the TCUDS, the Texas Christian University Drug Screen. Although the Texas Christian University Drug Screen is much more effective than the SASI in accurate classification of people with substance use disorders. So be careful about the instruments. But there's certainly a lot to choose from out there, and it makes sense to be a good consumer of the instruments. We want to make sure we use instruments that have been tested in justice settings, that are pretty easy to use, that are low cost. Again, the SASI is maybe the most expensive instrument out there for screening, but yet it's the least effective, so it's kind of paradoxical. A lot of the public domain instruments, the ones that we mentioned in the webinar, are free of charge and easily available on the internet. So just some considerations here. So finishing up, just some thoughts about conducting assessment and screening. We certainly, given the prevalence rates of these disorders, want to have a high measure of suspicion that we're going to see these disorders in our settings, right? We assume that we're going to see these until proven otherwise. We want to, in the course of screening and assessment, be non-judgmental. We don't want to be labeling people as being, an addict. We know that these disorders can resolve over time. Oftentimes, it's important to look at the sequence of the information that we gather, to look at non-invasive and non-embarrassing areas before we move on to other areas that might be more stigmatizing. So, for example, I think generally that we can gather substance use information before we look at mental health information and before we get into trauma. We look at other areas as well to gain rapport, and we look at things like education, past history of living situation, family members, education, employment, those kind of things that are typically less stigmatizing before we look at substance abuse and mental health information. Of course, to increase accuracy, we want to augment self-report with collateral information. Not to say that self-report is terrible, but it certainly can be affected by the context and is not always accurate, particularly for people with co-occurring disorders who may be under the influence of drugs or alcohol or may be affected by their major mental disorder at the time of the interview. So we want to, the collateral information here could be a correctional officer in jail or prison. It could be a family member. It could be somebody who resides in the halfway house as a house manager. It could be a case manager. It doesn't have to be a family member. And oftentimes these individuals have been estranged from family, so it's not really even possible to do that. Self-report data is not terrible. It's all we have sometimes. And it does provide unique information about substance use, mental health, co-occurring disorders. Accuracy of this information, we've done some studies in this area. It's moderately good. Moderately good information. It's increased accuracy, of course, with collateral information, as we just discussed. If we can compile this before we look at self-report data, that's always good. For example, from drug test results, one example, but also from family members or other collaterals, we have a baseline of information, a context to kind of weigh whether or not we're getting accurate self-report information from the offender. So there are mediators, things that affect the accuracy, and this is the type of substance abuse. For example, people with marijuana use have higher accuracy. People with heroin and cocaine use have lower accuracy for talking about those particular types of drug use. There is differences by age and other factors mentioned here. Also, importantly, for individuals to perceive consequences of reporting, this is kind of intuitive, I'm sure, has a big impact on the accuracy of information. So if you're telling people that the information is confidential, it's not going to be available to the prosecutor for somebody who's in a pretrial setting, that's going to give you a lot more accurate information when you conduct your intake screening and assessment at the point of jail booking, for example. All right, so just some considerations to think about. And then finally, we mentioned before that substance abuse can mimic every major mental disorder. So we have to look at the assessment process as one in which we may want to reassess over time if there's a chance that somebody's been using recently. And so even within a past week or 2 weeks, we can have some residual symptoms such as depression that come from use of stimulants, for example, methamphetamine, from other types of drugs that could be even residual to the detoxification process, withdrawal process from these drugs. And so we want to use drug testing whenever possible. We want to take a longitudinal history of the symptom interaction, as we talked about before, to look at whether or not we have bona fide mental disorders that are freestanding, separate and apart from the occurrence of substance abuse and the use of drugs and alcohol. And then, of course, lastly, we want to compile diagnostic impressions over time and then repeat this. Particularly important with the co-occurring population, in which we have rapid cycling of some of these symptoms, and also the accuracy of information may vary considerably according to the use of drugs and alcohol and the acute nature of this mental health symptoms. So to wrap up, where are we? We've got high rates of co-occurring disorders in justice populations in comparison to the general population, certainly. We talked about maybe 6 times the rates of these disorders, of both substance use disorders and mental disorders. We really expect to find both of these disorders in our settings, and when we have a mental disorder, certainly the vast majority of people, about 75%, have a co-occurring substance use disorder. We want to look across multiple domains, right? And that means implementing screenings in each of these different areas. So if you don't have a separate screen for trauma and post-traumatic stress disorder in your grantee setting, you need one. And it doesn't take a lot of money, it doesn't take a lot of time, and it doesn't take a lot of training to train up your staff to use these instruments. So again, each of these other areas, I'm sure you have developed an instrument. Hopefully these are standardized, psychometrically sound instruments. We discourage use of homegrown instruments for screening, particularly because there are many instruments out there that have very reliable thresholds for scoring that will tell you very accurately about whether or not somebody needs further assessment for any of these disorders. The good news, there are many evidence-based instruments on the screening and assessment side for co-occurring disorder, and we gave examples of several of those, but certainly not an exhaustive list. Again, that monograph that we described has many more examples of instruments and other considerations for approaches used in screening and assessment of co-occurring. So today, we also talked about the importance of screening and assessment across the different contexts and settings in which you work in your grantee projects. And that goes from law enforcement all the way to reentry, right? And again, the point there is that across the system, we need screening and assessment available for our offender population for the range of co-occurring disorders. And we may miss people at one setting, and when they cycle back into another setting or are arrested and booked in jail, we need to have available screening and assessment at that setting as well. And then finally, we talked about some strategies to enhance your screening and assessment process, and particularly the accuracy of gathering information in criminal justice settings. So I'm going to wrap up here, and I think we have time for some questions at this point. Hopefully there are some questions from the audience.
Yes, Dr. Peters, this is Allison Upton again, and thank you so much for your presentation today. It was so informative, and we do have time until the half hour for questions, and so we'll use the remainder of the time to take questions. And so I just want to remind everyone to please remember to use the chat box on your screen to continue to send in questions, and we're going to answer as many of them as we can. Before we do get started with the questions, I want to take a minute to make sure we have time to announce actually an upcoming webinar, which is also featuring a presentation by Dr. Roger Peters along with Jack Charlier and Phil Barber from TASC on Thursday, May 3rd. From 2 o'clock to 3:30 p.m. Eastern Standard Time, we'll be having a webinar on screening and assessment of opioid disorders. So this is a part 2, if you will, getting into opioid disorders, and so we will be sending out information about that, but want everyone to bookmark that date of Thursday, May 3rd for that training. So Dr. Peters, we have some questions coming in, and so I wanted to just start with one of them. And you touched upon some aspects of this during the presentation, but programs are reporting that they are working with people in a variety of settings who may be actively using alcohol or other substances, actively or just by relapse. And so can you speak a little bit more about how screening and processes might be impacted by this usage, and if so, how? Is it better? They're asking, is it better to wait until a person's not actively using or withdrawing to screen to get the most accurate answers, or should they go ahead? How does that process work? What would you advise?
So that's a good question. So what about active use of alcohol or other illicit substances? So one thing, if we step back, is that I would just mention briefly is that in the past, some programs have not wanted to take people because of active use of drugs or alcohol. And I think that's a bit short-sighted given the population of co-occurring disorder individuals that we work with, that we are going to have people who relapse and are actively using. We certainly want to have a period of abstinence before we engage them in treatment services that are skill-based, right? They require the ability to focus, to concentrate, and so forth. And certainly people who are actively using, that are drinking or using drugs, coming into our programs are distracting, and we can't really work effectively with them at that point. But for people with a recent pattern of use, we don't want to we don't want to say blanketly that we're going to restrict our program to people who have been sober for 30 days or whatnot. We really exclude a lot of the high-risk, high-need population that we really want to target. So that's the first thing I would mention. So I don't think there's one right or wrong answer here in terms of an approach, or right or wrong approach to doing this. I think we have to certainly take into consideration what people have been using recently and how that impacts their ability to be a good informant historically and about contemporary issues, problems, their own life situation. In some cases, I don't think we have a choice. I think we have to conduct screening with that population. They come into booking at jail and they're intoxicated. They've been using heavily over the past several weeks. We don't really have a choice of whether or not we're going to screen for mental disorders, suicidal thoughts and behaviors, suicide risk. We need to place people in services, and in some cases it's guesswork about the presence of a mental disorder. As we mentioned, that use of drugs and alcohol can mimic these disorders and can cloud the picture of what we're actually seeing and whether or not people have mental disorders, in fact. So we don't have the luxury of a lot of time in some cases, but I think if we do have the ability to extend the assessment process, that is the way to go for people in which there's a question about their recent use. And certainly we get a more accurate picture of the individual situation over time by conducting a more longitudinal assessment or a delayed assessment. In some cases, we can do an assessment over several different periods of time. And so it may be that we do an initial screening and assessment, and then we can wait for a period of time if we have somebody in a secure setting. And it allows us somewhat for the person to detoxify and able to participate more effectively in a full assessment process. And I think also what that does is allow us to share information about how the information is going to be used and how we can help people by gathering accurate information about their behavioral health disorders to place them in needed services in which they might actually get some additional benefits, such as housing, vocational training, maybe diversion from a correctional setting, an institutional setting, based on the ability to participate in a community-based treatment program. So I think those are all considerations. I don't think there's one right answer in terms of how long you have to wait. It really depends on the setting and the needs for gathering information rapidly in that setting or not. And so I think we have to be careful in terms of how we proceed with that. But ideally, we would want to have a longer period of assessment for people who have been actively using.
Great, thank you so much. Very helpful. And another question, you mentioned and you covered in your presentation today that it's important to screen across multiple domains related to co-occurring disorders, including mental disorder, substance abuse, trauma, /PTSD, and crim risk. Is there a specific order in which these domains should be screened, or is that irrelevant?
We touched on that. I think in general, and you know, there's really not good research on this. It comes from our clinical understanding, our clinical knowledge of working with this population. But again, I think the general rule of thumb is it's important to gain rapport and to gain trust and establish a personal relationship before you can really embark on a good assessment process, a good, reliable assessment process. And so to do that, we don't jump in and start talking about invasive kind of areas that might be stigmatizing or might be perceived as threatening in terms of, am I going to get placed in a intensive treatment program, or am I going to have some type of negative outcome in the justice system with my sentencing because I'm sharing information about my prior substance abuse and criminal history with the individual conducting the assessment. So we want to start with, first off, laying the ground rules about how the information is going to be used and what benefits there are in sharing the information, and in terms of how the assessment will be used to help the individual. I think we want to be very honest up front about who's going to receive this information, whether or not it's available to people who might have a say in the criminal disposition for the individual sentencing, at the point of sentencing, for example. And so, we worked and developed the in-jail treatment program here in Hillsborough County in Tampa years ago in the late 80s, and we had to work out a memorandum of understanding with the prosecutor that they would not request and we would not supply information from the initial interview about criminal history and so forth, or about the level of substance abuse, but that we would provide general recommendations about treatment that would flow from that interview process. So I think that's important to lay out the kind of parameters about how the information is going to be used, how it can help the individual, how involvement in treatment can help. But then we want to go into areas that are non-stigmatizing to begin with, and I mentioned those before. And there are lots of critical areas of psychosocial information, education, employment, family history, that come before some of the more stigmatizing areas of assessment related to substance abuse and then mental health. I think generally in our society, I think it's probably different in some societies. I think substance abuse is a little less stigmatizing and threatening for people to talk about than mental health disorders and problems and symptoms. So we try to get to the behavioral health disorders later on and talk about treatment history, diagnosis, acute symptoms, and so forth in the course of that towards the end of the assessment process.
Great, that makes a lot of sense. Thank you very much. And related, I think you've touched on some of these points, but there's a question about, with this target population of people with co-occurring disorders, is there any data to explore around exaggeration of symptoms for secondary gain or malingering? Does that have an impact on screening and assessment processes at all, or is that not really a large factor here?
I think it's a factor in some settings. I think that generally there's a tendency to underreport versus to overreport type of symptoms related to behavioral health disorders. But occasionally you'll find people who are in a forensic setting that will be malingering. And that's an area in which people are trained to conduct assessment interviews to identify kind of red flags related to malingering. And this would be something that a forensic psychologist or psychiatrist would encounter if they're conducting a competency or sanity evaluation, for example, and somebody's been has a been charged with a capital offense, and they're looking at, you know, a lot of prison time, and they may think that malingering and feigning a major mental disorder will help in some way. In reality, you know, going to a forensic hospital for a year or two, it doesn't oftentimes help and doesn't change the outcome of their case, but they may think that that is going to help them. And so there are actually formal instruments that look at malingering for individuals, and there are also just a number of kind of red flags. For example, if people aren't able to remember their birth date or how old they are, and yet they're able to hold a conversation, there's some, you know, things like that that would tell you that people are likely malingering about the severity of their disorders and their level of impairment. But so that is an area in which trained clinicians who are conducting assessment are looking at and will identify during the course of an interview.
Great, thank you. And probably time for one last question, and we'll shift to the final slides in our presentation with some information for the attendees. But Dr. Peters, can you just comment on fidelity for screening and assessment instruments and how programs can do their best to ensure that administration fidelity is being followed for these instruments you've described?
Yeah, fidelity is an important issue both for treatment but also for administration of instruments. And so I think the biggest factor with fidelity of screening and assessment instruments is using a standard instrument in your program. I'm still surprised when I visit programs in the criminal justice area around the country that are really some of the counselors are flying by the seat of their pants and conducting intake interviews, psychosocial assessments, and they may have, you know, a typical case might be where a program has 7 different content areas. It might be education, employment, substance abuse, treatment, history, mental health, other areas, housing, living situation. And then the counselors are asking their own questions within those domains of information. Well, guess what? You have a lot of variability in terms of the quality and the content of information that's gathered under those circumstances. And so that's why you need a structured instrument, and particularly ones that have properties that are demonstrated related to reliability, how accurate they are on readministration across different counselors and within the same counselor, right? Reliability, and also validity in terms of predicting whether or not somebody has a bona fide mental health or substance use disorder and is in need of treatment. So we want to use structured assessment and screening instruments that have these properties instead of using homegrown, fly by the seat of our pants types of instruments that we may have developed in our programs. I find it still pretty surprising talking to people in programs in which they are confident about using some of these homegrown instruments because they feel like they've worked in the past, yet they don't really have proof that they're valid and reliable instruments. So I think that's one of the biggest factors in fidelity.
Great, thank you so much. And the time passed very quickly today, so I just really, before we close up, want to thank so much our presenters today, Andre Bethia from BJA and Dr. Roger Peters. Thank you so much for participating in this webinar, and thank you to all of the attendees. We really hope this has been a useful and interesting training today. So we just encourage you as we're wrapping up today to contact Dr. Peters and myself if you have any questions after this webinar. And also, we really encourage you to if you haven't already done so, to join the NRC, visit the NRC website to sign up for our newsletters so you can get important announcements going forward about training activities. And thank you so much again to everyone, and we hope you all have a great day. Bye-bye.